Go.
Good morning, everyone. Welcome to Grand Rounds. Today, I have the special privilege of introducing a friend, someone who's made a very distinguished career, has been in a upright trajectory for the last 2 decades. Melinda Desai is the Harlem Family Endowed Chair in Cardiovascular Medicine, Professor of Medicine at the Cleveland Clinic. Is also honorary professor at University of Oxford and director of the clinical operations and the Hypertrophic Cardiomyopathy Center in Cleveland. He's got his degree in medicine from the Municipal Medical College at Gujarat in India. Then he moved to America when he did his training in internal medicine at the Southern Illinois University School of Medicine, following up with cardiology at Allegheny General Hospital, and then cardiac imaging training at the Johns Hopkins and then at the NIH. He joined the faculty at Cleveland Clinic just about the time when I was leaving in 2005. So we overlapped for a little bit, and I had the privilege of spending time with him as a colleague, and later on participated in many programs where we were jointly together. He had been focused primarily in hypertrophic cardiomyopathy, where he leads now one of the most important centers in the world for the management of patients with hypertrophic cardiomyopathy. He has authored some of the most important publications over the last 2 decades in this topic. He's an example of someone who's quite accomplished clinically, but also academically, and as a leader. So thank you again for joining us, Milin. We're looking forward to listen to your presentation.
Thank you, Mario. Thanks for the kind introduction. And you guys can hear me and see the slides, correct? Perfect. So it is my hope that in the next 45 minutes or so, I give you how I think about hypertrophic cardiomyopathy in the grand scheme of things. And here are my disclosures. So before we start, we need to do some simple math. HCM is thought to have a prevalence of about 1 in 500. Some folks seem to think the prevalence could be 1 in 200. If that's the case, there's about 15 to 20 million patients affected worldwide. In USA, we know of about 100,000. That means even in USA, there's about 85% patients that are undiagnosed, misdiagnosed, or underdiagnosed. So at the very least, what we have is lots of opportunities to improve diagnosis. And once that happens, lots of opportunities to treat. So, like everything else, step one cannot be anything other than multimodality imaging. You have to be able to establish the diagnosis and phenotype. You have to recognize, is there anything else going on? Then, once you have made the diagnosis, you have to be able to ascertain symptoms. Are they due to outflow tract obstruction? Is the obstruction due to basal septal hypertrophy, mitral valve problem, papillary muscle problem, or are the symptoms due to diastolic dysfunction without obstruction and mid-cavitary apical hypertrophy? You have to be able to ascertain the risk of sudden cardiac death and what are some of the familial and genetic implications. These 4 images on the right are all HCM patients, but they all look different. The top left is very thick septum, top right is apical HCM, concentric HCM, and the bottom right is somebody who has no hypertrophy due to papillary muscle problems. This patient, echo remains the mainstay, while cardiac magnetic resonance offers complementary value. We will talk about imaging in the next few slides. An important thing to realize, not all HCM is thick walls, and not all thick walls are due to HCM, okay? These are 2 examples. The one on the left is a person who's gene negative, but with massive hypertrophy of the septum and late peaking outflow tract gradient. This person, obviously, we treated them with a standard myectomy. On the right is somebody who has no hypertrophy, severe SAM, very symptomatic due to abnormal papillary muscle. And this person happened to be gene positive. So for this person, you cannot do a myectomy. We developed a new procedure, and we will talk about that in a little bit. Bottom line is, do you want to be looking like the kid on the top or a well-dressed person like the bottom? You know, it has to be a tailored approach. Another important aspect of HCM, especially the non-obstructive HCM, is the apical variant of hypertrophic cardiomyopathy. It is increasingly being recognized as a bad actor. Patients with apical aneurysm have a 6.4% per year risk of events, which is threefold greater than people who do not have aneurysms. So if you see somebody, first step is make sure you look for the phenotyping. If you diagnose apical variant, you have to make every effort to look for an apical aneurysm. Cannot underscore the importance of using contrast and adapting the views. Strain is emerging as an important factor in all other diseases. And a couple of papers we published large scale, which have shown that strain does provide incremental prognostic value. Not only prognostic value, but perhaps even ascertain differential diagnosis like amyloidosis. The images on the right are almost 2,300 patients in HCM Registry, which is an NIH registry, where we utilize feature tracking cardiac MRI and have determined that there are some aspects. I mean, what are the things that cause abnormal strain? Include the morphology, outflow tract obstruction plays into it, gadolinium enhancement, as well as abnormal T1 kinetics. So this field is in a state of evolution, and more to come in the next few years. So I alluded to the HCMR registry. That is almost 2,800 HCM patients from more than 40 sites across many countries. A lot of papers. I mean, this is in the closing stages of its long-term follow-up, and so in the next couple of years, I expect a lot of papers to come out demonstrating its incremental prognostic value of CMR and SCAR, etc. But we are learning a few new things, including, the association between sarcomeric mutation and the shape of the septum, more fibrosis in those patients, and different things we are learning as we are going along. Machine learning. Now, this is evolving rapidly, and in a sub-study out of the HCMR registry, in almost 2,400 patients, we have developed machine learning algorithms that can detect, based on the shape, who will obstruct, who may obstruct at rest, who may be genotype negative. So again, lots of evolution happening, lots of new stuff coming along. There's data emerging on artificial intelligence where you can utilize EKG and identify patients with HCM with a very high degree of sensitivity and specificity. But I'm going to very strongly caution everybody to look at this data carefully, because, as we all know, different ethnicities, especially African American ancestry, has a higher rate of ECG abnormalities without the diagnosis of HCM. So we have to make sure that we are, AI is not be all end all. You have to be able to know exactly what you're doing and make assertions. You cannot be adding any more angst to an already anxious patient. A few other things as it relates to AI. This is the image on the left, which showed that utilizing machine learning algorithms was found to be superior for wall thickness measurements and, of course, faster. Just recently, we published last year from, again, HCMR registry, where we can utilize machine learning to predict which patients are going to develop outflow tract obstruction, including various mitral valve and papillary muscle measurements. Step two, in my opinion, is it is absolutely important to be able to elicit outflow tract obstruction. If you don't look, you won't find, and if you won't find, you cannot treat. Obstruction is worse than having no obstruction. And it is important that you recognize that it is necessary to utilize all means. We use resting gradients, Valsalva, treadmill, bike, in many cases, amyl nitrite. At rest, gradients are seen in only 25% patients, but with provocation, it is seen in almost 70% patients. Again, I'm going to show you this image of a patient with no wall thickness who was told they were anxious. When we did amyl nitrite and put him on a treadmill, he developed all the symptoms with severe outflow tract obstruction. So, bottom line is designating somebody as non-obstructive HCM without the full extent of provocation is not appropriate. Stress echo, we utilize a fair bit of it in our patients, especially to help provoke latent symptoms as well as assess functional capacity. In many cases, we also, the gradients at rest are not very helpful, and we provoke severe gradients and assess MR along with blood pressure response and arrhythmias. In this study we published a few years ago, 430 patients that were deemed to be asymptomatic. They come to the clinic saying, we have no symptoms. We put them on a treadmill. Only 18% patients achieved 100% predicted meds. And the ones that achieved had an excellent long-term survival versus the ones that did not achieve their predicted meds. So there's a lot of value in doing stress echocardiography, and it is safe. Step three, always be on the lookout for typical and atypical variants of obstructive HCM. We have plenty of patients, and we were one of the earliest to describe a lot of patients have obstructive cardiomyopathy phenotype without the basal septal hypertrophy due to abnormal mitral and papillary muscle morphology. Majority of them are going to be the thick wall type, but you will see in a large enough practice, there's pap muscle abnormalities, portal attachment abnormalities, mitral valve abnormalities. And so fundamentally, designating somebody as not being HCM based on lack of LVH without the full extent of provocation is also not appropriate. These are three different patients of mine with three different flavors of atypical outflow tract obstruction. The top panel is somebody with elongated anterior mitral leaflet. The middle panel, no hypertrophy, but patient has bifid hypermobile papillary muscle. And the bottom panel is somebody who got operated for chest pain, thought it was angina, continued to have symptoms. We found that this person was having outflow tract obstruction due to abnormal chordal attachment. So three different, none of them have basal septal hypertrophy. Step four, always be on the lookout for phenocopies as well as other types of diseases. Strain has helped a lot. There are four different strain patterns. The top left is your standard HCM. Top right is your apical HCM with apex strain is low. Flip side is the amyloid apical sparing in the bottom right, where there is preserved strain in the apex and everything else is reduced. And hypertensive heart disease with just a normal appearing strain. You can utilize CMR with gadolinium to assess differential diagnosis for Fabry's disease, amyloid, athlete's heart, etc. Fundamentally, it is important to go the distance if you suspect a different disease process, especially now that we have drugs for HCM as well as amyloid and Fabry's disease. It is important to make the correct diagnosis. These are 2,500 myectomies done at Cleveland Clinic. What we found when we looked at the pathology, even in an experienced center like the Cleveland Clinic, 1 in 5 had an alternative diagnosis. So it is important to be humble and be on the lookout for something that doesn't make sense, if it doesn't make sense. Next step, it is crucial to do risk stratification in these patients. And there are two schools of thought. The North American school of thought involves categorical variables, malignant family history, severe LVH more than 30 millimeters, unexplained syncope, non-sustained VT, gadolinium enhancement more than 15% of LV mass, burnt out HCM or apical aneurysm. Again, this is why looking for apical aneurysm is crucial. The Europeans use a continuous formula based on many similar criteria to come up with a sudden cardiac death risk score at 5 years. And if your score is more than 6%, ICD is indicated, less than 4%, it is not recommended. Which one is better? Bottom line is you need to use at least one or both. But this study has shown that the number needed to treat to prevent one sudden cardiac death is lower with the American ACC/AHA guidelines versus the ESC guidelines. So it has it is more sensitive as you are trying to pick a needle in a haystack. Bottom line is, when do you recommend ICD? If you had a prior event, ICD is class 1. If you have one of the risk factors that we talked about, ICD is reasonable. If none, look for non-sustained VT. If you have it in a child, ICD is reasonable. In an adult, if you have non-sustained VT and extensive myocardial fibrosis, ICD could be considered. Just to permit participation in sports is not an indication to place an ICD. Multiple papers have been published in the context of myocardial fibrosis assessment and outcomes. This is something we published a few years ago in more than 1,400 patients, where we have shown that 15% myocardial fibrosis is a cutoff for association with adverse outcomes. And that is also what is utilized in the guidelines. And we showed it in all groups: obstructive, with or without myectomy, non-obstructive. This provides incremental prognostic value. Of course, the HCMR registry will help us further ascertain whether this indeed provides incremental value. Screening, echo for first-degree relatives is an important tool. So cascade screening is necessary, and in poor images, or if there's suspicion, then CMR can provide adjunct value. So genetics and imaging, the combination of two, have to be utilized in terms of screening for family members as well as genotype positive, phenotype negative patients. Now I'll focus mostly on management. At baseline, at the very least, you need to be doing lifestyle modification. So along with assessing the risks, screening family members, control symptoms, volume depletion, isometric exercise assessment, avoiding the wrong kind of drugs are some important things. It is important to be able to recognize which medications to avoid, especially ACE, ARB, nifedipine, digoxin, nitroglycerin. Beta blockers, verapamil, diltiazem, and disopyramide have been traditionally used, and we will talk about that in a second. It is crucial to screen for obstructive sleep apnea because they go hand in hand. Lifestyle consideration. So there's emerging data, and yesterday, and I will talk about that in a second, there's fresh data coming about physical activity. But shared decision-making is important. Pregnancy, we never not advise patients to get pregnant. It's just shared decision-making is important, and initiation of guideline-directed therapy. It is important to manage comorbidities because they add fuel to the fire. Endocarditis prophylaxis, the guidelines don't recommend, but again, shared decision-making is important. So this was published it was published literally 20 hours ago as a late-breaking trial yesterday at ACC, the LIVE-HCM Trial. 1,500 patients from 8 to 60 years, all HCM, 42% exercise vigorously, 43% moderately, and 16% inactive. what the primary endpoint showed that there was no difference. There was no increased primary composite event of mortality, arrest, arrhythmia, etc. Secondary analysis showed no difference between vigorous sedentary, moderate sedentary, and vigorous versus moderate group. So bottom line is this field is rapidly evolving and the guidelines should change about restriction of physical activity. Moving on to therapies. There are no real prospective randomized controlled trials comparing various FDA-approved medical therapies, invasive therapies versus FDA-approved medical therapy, and myectomy versus alcohol septal ablation. There's some data. Disopyramide. New York has played a big role in use of disopyramide, but most of the data on disopyramide is retrospective, observational, and diso has a lot of side effects. Recent study has shown that beta blockers, prospective study, can lower LVOT gradients, reduce dyspnea, but it did not make a change in maximal capacity. So currently, most of the recommendations are level of evidence C or consensus opinion. It is important to recognize that medical treatment cannot be worse than the disease. We have to be careful about over-treatment in terms of orthostasis, dizziness, bradycardia, QT intervention, QT interval prolongation. Erectile dysfunction is a big problem in young men. Overzealous restriction of physical activity results in deconditioning, obesity, and all those things that we know about. Generic drugs and not having good impact is a real thing and should be taken into consideration. So sometimes you reach a point where enough is enough, and sometimes septal reduction therapy is the best option. So, as I alluded to earlier, septal reduction therapy is not a one-size-fits-all. In majority of the patients with thick wall, you do a myectomy. But if you have no thick wall, then you've got to get creative. You need to work on your mitral valve. You may need to work on papillary muscle, where we reorient the papillary muscle away from the outflow tract. Bottom line is you need an experienced center with an experienced team of providers. If you have that, this is data from 2,300 Cleveland Clinic patients where we showed that doing surgery, the image on the right, if you do isolated myectomy or myectomy in combination with mitral valve procedure, there's no outcome penalty. And if you, at a place like Cleveland Clinic, if we offer a slightly earlier surgery at class 2 with drug intolerance, the outcomes were better than waiting for patients to develop symptoms. So we routinely offer surgery, have been routinely offering surgery for drug intolerant patients or people with symptoms who also have impaired physical activity. If done right, quality of life after surgical myectomy, this is data we published last year. Significant improvement in Kansas City summary score, bigger than anything else, almost a 35 to 37 point absolute increase in Kansas City score at 1 year. Alcohol septal ablation is something that can be used at the Cleveland Clinic. We routinely use it if the patient is not a surgical candidate, but it requires appropriate perforator anatomy and adequate size septum, no pulmonary hypertension or papillary muscle issues. So it is important that experience is also necessary here and right anatomy. When do we recommend? The guidelines recommend invasive therapy. Experienced providers for severe drug refractory symptoms and outflow tract obstruction consider doing additional operations if there are atypical variants. In advanced symptomatic patients where surgery is not an option, recommend alcohol septal ablation. Now, these guidelines have also evolved, and if you have pulmonary hypertension or AFib, poor functional capacity, experienced center where patients don't tolerate medical therapy. So these are class 2B indications suggesting an earlier operation. Of course, operating on asymptomatic individuals or just routinely doing mitral valve replacement is a class 3 indication. But it is important to recognize, if you just do simple math, we don't have enough good surgeons, and we don't do enough good procedures. There's a lot of patients on the left hand of the spectrum with mild disease who may benefit from medical therapy before we talk about doing heart surgery. Also, it is important to recognize that expert centers have better SRT outcomes, and there are not enough expert specialty centers. If you go to an expert center, death rate is 1 in more than 1,500. If you go to a low volume center, it is 1 in 6. So you should always send the patient to an experienced center. But what is the reality? This is something we published a couple of months ago. Medicare analysis reveals that myectomy is better than alcohol in the long run. Both of them reduce heart failure burden, and there is an inverse association between worse outcomes and higher volume centers. Having said that, 70% patients undergo SRT at low volume centers. So guidelines are good, but people are not following the guidelines. That's why I think there is an unmet need to increase the tent that offers more treatment alternatives. That brings us to cardiac myosin inhibitor. Mavacamten is first in class. It is an inhibitor of myosin. So HCM has a hypercontractile state. So Mavacamten makes the heart contract normally. Heart also has impaired relaxation and abnormal myocardial energetics. So Mavacamten improves all those things also, and it is thought to have a low arrhythmogenic potential. In basic science study, it has shown to prevent disease phenotype. It reduces pro-hypertrophic and pro-inflammatory signaling. It also reduces the development of myocardial fibrosis. So lots of basic science data pointing us in the right direction. What have the phase 3 randomized controlled trials shown? So till now, nothing in HCM was prospective data. Now we have few randomized controlled phase 3 trials. The two done in the context of Mavacamten include EXPLORER-HCM, which included mildly symptomatic class 2 and 3 symptoms. Patients on monotherapy with beta blocker calcium or disopyramide, and Valor-HCM, which is advanced symptomatic patients on maximally tolerated medical therapy, including potentially disopyramide. Every patient was referred for surgical myectomy or alcohol septal ablation. What did EXPLORER-HCM show? 73% patients were in NYHA class 3, significant improvement in resting and provocable gradient without worsening of ejection fraction. And the primary endpoint of significant improvement in functional capacity as well as NYHA class was seen in Mavacamten group compared to placebo. It also resulted in a significant improvement in quality of life, with 36% demonstrating a large to very large improvement in Kansas City summary score. Additionally, all the biomarkers, the BNP as well as troponin, trended in the absolute right direction in the context of Mavacamten compared to placebo. It has also shown a favorable impact on cardiac structure with LV mass regression, wall thickness regression, stabilization of myocardial fibrosis without significant deterioration of clinically meaningful ejection fraction. So this has the potential of changing cardiac structure in a good way downstream in the long run. Recently published again in January, every aspect of cardiopulmonary exercise testing was improved in favor of Mavacamten compared to placebo. Long-term extension study, lots of data. Now we have up to 5-year data, which is showing it is safe. Ejection fraction does not significantly drop, and the gradients remain persistently low. Patients continue to feel significantly better in the long run. That brings me to the Valor-HCM trial of much sicker patients, 92% NYHA class 3, done in 19 US HCM centers. This was a 2-step study. The first step, 16 weeks, was placebo-controlled, Mavacamten versus placebo. where the drug titration was real life EF and gradient measurements. The question that we asked was, if we add mavacamten to maximally tolerated medical therapy, will that allow these severely symptomatic patients to no longer remain eligible for surgery or alcohol septal ablation? Second phase of the study was the placebo arm moved over to mavacamten, and we wanted to see what happens to that group as well as the other group in the longer term. So let's look at what the results showed. The primary endpoint, remember, at baseline, every patient was a candidate for septal reduction therapy and was referred. At 16 weeks, 82% patients no longer met criteria for SRT. And at 32 weeks, 89% no longer met criteria. Compare that to placebo, vastly different. NYHA class improvement was significantly different or significantly higher in the mavacamten group, both at 16 weeks as well as 32 weeks compared to placebo. And this was a real life study with 32% patients on combination therapy, including disopyramide. At 16 and 32 weeks, patients were offered a chance to switch over to SRT, and 95% patients chose to continue on medical therapy. What about the secondary efficacy endpoint? Both resting and Valsalva gradient significantly improved in the mavacamten group and remained low in the placebo group till week 16. They were high, and then you can see how nicely they go down. Similarly, KCCQ score improved in the mavacamten group and even in the placebo group after week 16. Importantly, ejection fraction has remained over 60% in vast majority of the patients. Favorable cardiac remodeling, again, biomarkers, mass index, LA volume index, everything trended in the right direction in the mavacamten group. Even markers of diastolic function like E over E prime significantly improved in the mavacamten group. Mitral regurgitation significantly improved in the mavacamten group versus placebo at week 16, as well as I alluded to, 1 grade improvement in diastolic function was seen a significantly higher proportion in the mavacamten group. You know, sometimes a picture is worth 1,000 words. 71-year-old patient of mine failed alcohol ablation after ablation in class 3 NYHA symptoms and unable to do activities of daily living. We put him on mavacamten at week 32. At baseline, look at his ECG with LVH strain pattern. Outflow tract gradient severe. 32 weeks later, ECG has normalized. Normal ECG gradients are gone. So we are seeing this repeatedly in many patients. So there's something about the story that is still being unraveled. But normalization of ECG, we think, is a pretty big deal. As I alluded to, EF, there has been concerns raised because this is a myosin inhibitor, but so far the story is that the significant drops in EF we are simply not seeing in clinical practice. Mavacamten was approved by the FDA under the risk evaluation and mitigation strategy because of concerns about EF drop and drug-drug interactions. These have to be taken into account, and you as a prescriber have to be cognizant of this, so along with the patients. And bottom line is, this is our protocol of how we manage. Patients get enrolled, we get enrolled, place the order, specialty pharmacy does their magic. If you're approved, you start the drug with follow-up echo at 4, 8, 12 weeks, and then every 3 months while taking mavacamten, which is commercially known as Camzyos. Next in class is aficamten. Again, this is currently being tested in phase 3 trial, the Sequoia trial. Redwood-HCM was a phase 2 trial, which, similar to mavacamten, is showing reduction in gradients, but without significant impact on LVEF and significant improvement in symptomatology. What I'm also excited about is emergence of gene therapy. Adenovirus-mediated gene therapy is now being developed in phase 1 study. We are going to be helping lead this program, where one dose of gene therapy can potentially replenish the protein that is in short supply and potentially cure the HCM. So now we are talking curing HCM in MYBPC3 type mutation. Just last week, genome editing was published by the Boston group, Cricket Seidman and colleagues, which shows genome editing can prevent HCM in mice. So lots of new stuff happening in this context. We have to assume, and assuming long-term safety and efficacy, we need to answer a few questions. How often do we need to continue to monitor? Who dispenses these new medications? Is it center of excellence only, primary cardiologists, or anybody can? What is the cost of long-term treatment with medicines versus one-time cost of surgery? An important question is, based on what I just showed you, would you have a suboptimal SRT at a less experienced center or have unsuitable anatomy? Or would you have a trial of Mavacamten? Should we be taking the conversation upstream and consider this as first-line therapy? We've not yet talked about non-obstructive HCM because there is no drug for that. I am pleased to announce that I'm leading a study, a randomized study, Mavacamten versus placebo in non-obstructive HCM, the Odyssey trial, which has started randomizing patients. So more data to come in the next few years. How do you currently manage non-obstructive HCM? Once your EF drops to less than 50%, or if it is preserved EF, treat it like beta blockers and calcium channel blockers. But once the EF drops, you have to be very careful about stopping these therapies and then treating them with guideline-directed medical therapy. In some selected patients, we use apical myectomy to debulk the myocardium to improve the stroke volume and help the patient symptomatically. You have to be careful about a symptomatic non-obstructive patient in terms of serial assessment. If you have increasing diuretic requirement, arrhythmia burden, biomarkers going up, dysfunction and organ dysfunction, worsening fibrosis, decreasing functional capacity, these patients are bad actors and you may need to consider them for transplant. AFib is a really, really bad actor in this context. And we've shown in this meta-analysis that it is associated with significant adverse events, no matter what data set you use. Getting onto it early is crucial because success rate for ablation is less than 50%. And at least in our practice, we utilize, if you're obstructive, you most definitely will get symptomatic, and we utilize it as a trigger for earlier surgery. Any AF, in my mind, is a sign to utilize Coumadin or anticoagulation. Don't wait for the CHA2DS2-VASc score. Genetic testing, lots has been written, and this is a rapidly evolving field, but fact of the matter remains, if you screen 100 patients that look HCM, no more than 40 of them will be positive for genetic mutation. So you still have to have a game plan for treating the rest. But this data is rapidly evolving. How do you test genetically? If you have a gene-positive patients, then you do cascade testing in their first-degree relatives. Otherwise, I typically bring them back every 3 to 5 years. Share Registry is gonna shed a lot of light in terms of genetics and long-term outcomes. So more data to come. There will be some mutations that we think will be more malignant than others, but remains to be seen. How do you screen? Typically, genetic testing is the way to screen, but otherwise, EKG and echo 1 to 2 years in kids, every 3 to 5 years in adults. Early stage HCM, especially their non-obstructive VANISH trial, has shown that compared to placebo, valsartan made a dent in reducing LV wall thickness or stabilizing it mass as well as volume. So remains to be seen how we are going to tackle this group. But suffice to say, the pediatric HCM is going to be the next therapeutic frontier. So to conclude, future is truly bright in HCM. Precision medicine will add an additional option in our fight towards a normal life. It is certainly not about my pill is better than your procedure, but what we can do to provide the best quality of life, because ultimately we have to keep patients first. I will end by saying, once new science rolls over, if you are not part of the steamroller, you become part of the road. So I think it's good to start the journey and hopefully continue it in the exciting path. Thank you so much for the invitation, and I'd be happy to answer questions.
Well, I don't know if Dr. Garcia is in line there, but Dr. Garcia, I just want to take the lead and just first of all, really thank you for taking the field where it is right now, and all I know, I think I learned it from you, and I can see that since the last time I heard kind of a lecture from you, I think things have changed a lot. I think I can see more than 50 new slides since I was in Cleveland. So, which is, that kind of really shows how the field has kind of, evolved and has changed, which is with many options, which is, a great thing, a great problem to have, as Dr. Meno would say. But anyhow, Dr. Garcia is here, so Garcia.
Oh, thank you, Milling. I would concur with Aldo. Obviously, the big question we have, I have quite a few questions that I wanted to ask you, but the main one, of course, is what is the niche, in your opinion, honestly, about current use of Mavacamten in patients who are eligible for myectomy? How many in the Valor trial were potentially candidates for myectomy, and when do you choose one versus the other?
So all the patients in the Valor trial were candidates for myectomy, all 100% of them. There was no patient that we thought was wishy-washy. So that's the right now. So what we have done, the way I think about it is there's going to be different types of patients. One is, I do not want surgery. So can I try medical therapy first? The other one is, I'm not ready for surgery. I want to see how I feel. Maybe down the road, I could do surgery. The third group is, I have high risk for surgery and my alcohol ablation septal perforator is inappropriate. So that's the group. The other, I think the bigger group is lack of access. There's not too many good myectomy or alcohol septal ablation centers around the world. And, there's clearly a inverse association between volume and outcomes. So that's why I made the comment, is it worth your while getting a suboptimal myectomy in a low volume center or give Mavacamten a shot? So I think, these will shape out. So what are we doing at the Cleveland Clinic? Here, there are some patients who still come and say, you know what? I don't want to talk about medicine. I just want to get operated upon and move on with my life. Free country, that's fine. But if they are open to a conversation, we discuss, here are the options. What do you want to choose? And so truly it has gotten to be shared decision making. And as we saw in the Valor study, 95% vast majority of the patients are saying, let me try this first.
Yeah. I mean, the concern that I have, of course, is when you test a new therapy, you test it against the standard of care. Symptomatic surgery is superior than the standard old conventional medical therapy, which was used as the gold standard in Valor. So a patient coming to you asking that question, well, what is better? We don't have that answer for that, right? We don't have a comparative studies. Probably won't be done.
It would be impossible. I think, Mavacamten versus myectomy, I doubt if something like that is going to be done. So look, when we were planning the Valor study, I was at the first meeting, obviously, and, that thought came about, but this was even before the pandemic. So, there's no way at this point of time there's an appetite to be doing a head-to-head trial like that, medical therapy versus, and maybe there will be a time down the road where it would be. The fundamental thing is even the surgical data is not prospective. Most of it is observational data from large centers. So it is what it is. But at the end of the day, what I see this is it opens a large avenue, it increases the size of the tent that patients can choose from. The buffet line just got bigger. Okay. There's a couple of questions in the chat. Given the reverse remodeling data, do you see role of mavacamten in diastolic heart failure down the road? I think so. So, HCM is a good example of advanced diastolic dysfunction. And the fact that we are seeing some signals in this, I think the non-obstructive HCM population will give an answer, because there we are not treating the outflow tract gradient. There essentially we are treating the degree of hypertrophy and diastolic dysfunction and myocardial energetics. So I think, yes, the field is going to evolve towards testing it in diastolic dysfunction cases. There's a second question here. It says, sudden cardiac death predictor calculators in an elderly population. So typically, most of us would not utilize these calculators in folks over 65. And the accuracy falls down. And the way I think about it is, if you made it to 65, 70, I mean, the Darwinian theory of survival of the fittest. So, I would not worry about this unless there's documented VT with syncope, etc. Those may be slightly different.
Dr. Sai, if I might ask a couple of questions, when I was back in the Cleveland Clinic, I think, either to your clinic or some of the other, people there, kind of the protocol was just get, the patient neural agents and maybe double agents and see if that can improve, of course, symptoms and LVOT gradient at the same time. We'll prove it with exercise and so forth. And then if the patient was there failing, then we'll go, to surgery and take into consideration all the different aspects that goes into obstruction. Now with the Explorer data to say that combination was not allowed, but now the Valor combination therapy is okay. So how is the workflow right now in your clinic? When you see a patient for the first time has symptoms of LVOT, you go with neural agents, you go double neural agents, and then mavacamten versus surgery. So how's the workflow for you in terms of managing these patients?
Yeah, so that's a very important and an interesting question, especially in this center, we have everything available. So, if you are a de novo patient, first time diagnosis, so obviously we discuss lifestyle modification and all those things. Get rid of the bad medications that may be adding to the outflow tract obstruction. We still, and the insurance companies, I think, are going to be driving this more than anybody else. We still start them on at least one agent. So most commonly beta blocker, or if not tolerated, then calcium channel blocker. Then, our threshold to moving to mavacamten has obviously gotten lower. One thing I will tell you, and this has been my bias, and it's only going to get worse. And this is my personal bias. To me, after beta blocker, I am not going to move to disopyramide. And disopyramide already has side effects. At the clinic, only 3 to 5% of our patients are on diso. I mean, and that's just the way it has evolved. And so what happens? So that's my bias for monotherapy. If somebody comes with multiple therapies, and then we have a heartfelt conversation, surgery or this, and if the patients decide to go on the route of mavacamten, then I initiate mavacamten, and then when we bring them back, then I'm thinking about down titrating some of the other medications. So if you are on 200 milligrams of toprol and fatigued out of your mind, I'm going to push the envelope and see what happens when you are lowering those. Certainly, if they are on disopyramide, I'm also going to do that just about as aggressively. And so far on all the patients that we've started on Mavacamten, maybe one or two that have transitioned to surgery because they didn't tolerate this or something happened. We've seen some cases from outside. Our surgeons have direct referrals where, similar, we will have some cases where patients don't tolerate it or EF drops or the insurance company gives them the runaround or they just don't simply want this. So it's not going to be a one size fits all.
My second one, sorry that I'm taking over, but one situation that I think I struggle a lot, particularly here at the Bronx, is that, compared to like the pure hypertrophic cardiomyopathy patient with obstruction that is like nicely booked, case, we get these folks with obstruction, hypertrophic cardiomyopathy, but also have like severe hypertension, and I think there's like coexisting disease based on like entire workup, But you start with the novel agents and you try to maximize that as opposed to pure vasodilators. But these patients still persist with blood pressure in the 180 and have some degree of obstruction and symptoms. So then you start like, okay, so how do I really like get this under control? I guess that if you relieve the obstruction, either with medication or surgery, then you get that out of the equation. But if you're stuck, how you deal with these situations in terms of blood pressure management? Is ARB a potential compared to others, given the fibrosis data that is like still kind of debatable, or clonidine? How do you deal with this in this situation where you cannot relieve the obstruction, right away?
So I think that's a very important question. Before Mavacamten came out, hypertension was a big and a troublesome deal. So you give beta blocker, you give calcium channel blocker, they are poor antihypertensives. And then, not too many options. I've tried patients on clonidine, etc. It was always a hard sell to a patient. Let me send you to heart surgery so that I can treat your blood pressure better. Patients look at you and say, what? So, but now with Mavacamten, what has happened is, what we are doing, and we've seen this in many patients, the blood pressure is a problematic. What I say is, let's ride this through for a little bit. Let's put you on Mavacamten, see you back in a month. Oh, your gradient is next to nothing. Now I can introduce lisinopril or ARB or Norvasc or what have you. And in fact, last week, just before I went to ACC, there was a patient of mine who was uncontrolled hypertensive. And this strategy, her blood pressure is now in the 120s and she's feeling much better. So, and even at ACC, we were at a couple of panels and I was talking to some of my other colleagues across the country, and they're also seeing the same thing. So I think, good unintended consequence would be better managed blood pressure with normal standard agents. I think there is a question here from who I know is an electrophysiologist. So I am not an electrophysiologist. AFib ablation and HCM, usually best thing is ablation, but require non-PV triggers and average of 2 procedures. What do you recommend? So number one, what I tell my patients is, if you have AFib, we treat the AFib earlier. If they are a surgical candidate, we send them for surgery earlier, and I recommend a full cut and sew maze with left atrial appendage ligation. I always have shared decision making with my patients, and this is what I tell them. It's only a half joke. It's like, no matter what the success rate the electrophysiologist or the surgeon gives you, reduce that number by 10 or 20%. So if your surgeon says 70% success rate, I say it's 50 to 60%, because we've just seen AFib is a bad actor and we need to jump earlier on it.
Melina, I have 2 questions, if I may. One is related to AFib, since you mentioned, and I agree. Certainly the one of the worst conditions to have atrial fibrillation combined with this HCM, not only because of the difficulty controlling symptoms, but the very, very high risk of a stroke. Do you have any data on left atrial appendage closure compared with anticoagulation in these patients? And the other question I had is related to what you very clearly demonstrated, that there are patients that have pathology of the mitral valve that is predominant. Whether you have any experience using mitral clip alone or in combination with alcohol ablation?
Yes. So first question, I think not necessarily in the context of HCM, but there's emerging surgical literature that LA appendage clip is better than just pure anticoagulation. I know there was just a recent analysis in the Watchman literature which showed that it also has better value. That was a paper. I think that paper is getting a lot of bad press, but there was data that suggested that it is better than anticoagulation. The other aspect, yes, Paul Saraja at Minneapolis Heart has published a paper in patients with advanced HCM who are not really surgical candidates. Mitral clip may have a role, especially if it is a primary mitral valve pathology. I will tell you where all these things are coming into play in an unusual field is the folks who are undergoing evaluation for transcatheter mitral valve replacement. So primary mitral valve pathology. A lot of these patients, they're older and they have very narrow outflow tracts. And once the new valve is put in, there are some episodes of outflow tract obstruction. So the concept of neo LVOT prediction is real. And that's where I've seen providers do alcohol septal ablation, as well as, think about the mitral valve and can we do a clip to avoid this. So it may or may not be in the context of HCM, but certainly that anatomic interplay is being thought of and addressed. And there's something else that is there. The Chinese group from Xi'an has presented. So radio frequency ablation. So not using alcohol ablation, but RF ablation to shrink the thickened basal septum. So that there's also a paper that was published recently. I didn't mention that, but so more and more people are thinking along those lines. Lots of new stuff coming.
Elaine, thank you so much again for sharing your time and your wisdom. Looking at your background, the trees are green and blooming in Cleveland, and the grass is green. I suspect that the picture is not reflecting current reality.
No. This is just a picture. We have to pretend that this is just,
it's wishful thinking, which is the experience there.
But it's sunny and hardly any snow like you guys. So, on this part of the world, climate change results in no snow in February. So anyway, thank you so much for the invitation. And I had a great time and look forward to seeing you guys again in person at some point of time in a meeting.
Thank you, madam.
Thank you.